Picture this. You're at the bedside, stethoscope in place, and you're listening to a patient's breathing. You hear the normal in and out, but then there's something else, a subtle kind of poppy sound. What is that? And way more importantly, what's it telling you about what's going on deep inside those lungs? That's exactly what we're going to break down right now.
So you hear it, that unmistakable crackling or popping. The big question for any clinician is, what does it mean, right? It's not just some random noise. It's a critical piece of the puzzle. And by the time we're done here, you're going to have a solid framework for turning that sound into a really meaningful clinical insight.
Okay, first things first. Before we can figure out what the sound means, we all have to be on the same page about what exactly we're listening for. Let's get a clear definition. Now, the words here are really specific for a reason. Discontinuous. That means they're not a constant sound like a wheeze, you know? They're short, separate, little explosive sounds. And the best words to describe them are popping or bubbling. Seriously, think about the sound of pouring milk on Rice Krispies. That's the kind of auditory texture we are talking about.
So what's actually making that noise inside the body? Well, it pretty much boils down to one of these three things. First, you could literally have air trying to muscle its way through fluid or some other gunk. Second, and this is a classic one, those tiny little air sacs, the alveoli, they could have collapsed and are now suddenly popping back open when the person breathes in. Or third, the walls of the small airways could be kind of sticky and stuck together, and you're hearing them peel apart. Any one of those can create that signature crackle.
All right, so we know what they are and how they happen. Now let's get to the most important part, the why. Why does this sound matter so much when you're trying to figure out what's wrong with a patient?
And this, right here, is the absolute heart of it. When you hear crackles, your brain should immediately jump to one of two big ideas. Either there's fluid where there shouldn't be, or those tiny alveoli just aren't opening and closing the way they're supposed to. That's the top-level message your stethoscope is sending you.
So once we have that core message in mind, fluid or poor ventilation, we can start to connect the dots. We can take that general problem and start linking it to some very specific and very common medical conditions. And you know, when we're talking about the most frequent causes, the list gets pretty short pretty fast. In a real-world setting or even on an exam, hearing crackles should immediately make you think about one of three main culprits. And this lays out that connection perfectly. So for pneumonia, what's happening is that the alveoli are filling up with fluid and all that gunk from the infection. With congestive heart failure, or CHF, it's the classic pulmonary edema. Fluid is backing up into the lungs. And then with ARDS, acute respiratory distress syndrome, you get that fluid buildup too, but it's also combined with stiff, damaged alveoli that really struggle to pop open. So you see, three totally different diseases, but they all create that same fundamental problem that causes the sound. Okay, you ready to level up your skills a bit? Because not all crackles sound exactly the same. A really experienced ear can start to pick up on the subtle differences between fine crackles and coarse crackles, and that gives you a whole other layer of information. This is such a key distinction. Fine crackles, they're higher pitched, more delicate, almost like the sound of Velcro being pulled apart slowly. You often hear them later in the breath. They usually point to problems in the tissue between the air sacs. Think early CHF or fibrosis. Coarse crackles, on the other hand, are louder, lower-pitched, and sound wetter. They suggest that a more significant amount of fluid is just sitting right in the larger airways. The quality of the sound itself can help you start to zero in on where the problem is. All right, so you've heard crackles. Maybe you've even decided if they're fine or coarse. What's next? Well, there's this incredibly powerful, super simple test you can do right at the bedside that gives you even more clues. It's the cough test. And the procedure really could not be any easier. You find a spot where you hear crackles. Then you just ask the patient to give you a good, strong cough. As soon as they do, you put your stethoscope right back on that same spot and listen again. The whole game is about answering one question. Did the sound change? And how you interpret the result is just so logical. Look, if the crackles are still there, even after a big cough, that strongly suggests the fluid is way down deep inside the alveoli, where a cough just can't reach it. That points you towards things like CHF or pneumonia. But if the crackles change, or maybe even go away completely, that tells you the source was probably just some secretions in the bigger airways, that the cough was actually able to move around. It's such a simple test, but it has really powerful implications. And ultimately, this is what it all comes down to. Listening to the lungs isn't just about passively identifying a sound so you can check a box on a chart. No way. It's an active process of interpretation.
You're using sound to build a mental picture of what's going wrong, to really understand the story that the lungs are trying to tell you.
So now you have the entire framework, from the basic definition all the way to the little nuances of the cough test. But the real learning happens with a stethoscope on a real person. You know the theory now. The only question left is, when you're there at the bedside, can your ears pass the test?